Good evening, everyone. Welcome to our new webinar series on lifestyle medicine, and this is the starting webinar of this series. My name is Dr. Himal Kalambaraji. I'll be coordinating this session on behalf of Sri Lankan College of Internal Medicine. So let me invite our president of the college, Dr. Madhuanti Hettiarachchi, to address the gathering. Madam, session is over to you.
Good evening and very welcome to today's session. As the President of Sri Lanka College of Internal Medicine, it is my pleasure to warmly welcome you to this session, and I'm really glad that there's a very good participation for this important discussion on lifestyle medicine. And this is relatively new concept, yet one which actually beautifully aligned with our theme for this year. The college theme for 2026 is Decade of Inspiration, a Future of Innovation. As we reflect on innovation, one of our key pillar is prevention actually. So that is the sole purpose of starting this lecture series also. And as we are dealing with a lot of NCDs with a lot of cardiometabolic risk factors, which is in abundance, I think it's our duty to educate everyone of us, especially our internal medicine physicians as the so-called VPs, who actually do a lot of work to give solutions to the complex situation, especially in the curative medicine. And it's our duty to make our life easier by looking into the preventive aspect as well. So I would like to extend my sincere gratitude to our speaker today, Dr. Samandika Saparamadu, who is joining to share his expertise on this particular subject from John Hopkins Hospital. Amidst his research and academic activities, I wish to thank you on behalf of Sri Lanka College of Internal Medicine, and my special thank goes to Dr. Himal Kalambarachi also, because when I want to introduce this concept to the college, who actually have helped me with this subject is Himal, and he introduced to the speaker, and he will be coordinating this session today, and will be coordinating the future sessions as well. And I should thank Mr. Dishan and Nimanta with the GATES team, who is doing, as usual, excellent service for the audio visuals, and the behind scene usual pre-intern doctors of our college, Dr. Tishila, Dr. Uwin, and Dr. Nosaya, as well as Ms. Chintani, and our two joint secretaries, Dr. Ranga Gunasekar and Dr. Yusuf, along with our treasurer, Dr. Turba. They are all helping us to take these webinars forward without any hiccups. So to all the participants, thank you very much for joining. And please remember to scan the QR code, and we'll be asked a few questions also on this particular topic. So your engagement is actually very important. Please make use of this important topic, and try to incorporate this into your practice as well. Thank you very much. Over to you, Himal.
Thank you, madam. Today, our lecture topic is integrating lifestyle medicine into internal medicine and primary care for chronic disease prevention and management. Before starting lecture, let me remind you our few ground rules. We want you to keep your all mics muted, and you can send your questions to the Q&A or through the chat box. QR code and the link for CPD points and the certificate will be shared at the end of the lecture, and it will be active for few hours, and you will be receiving the certificates through the Google form after filling Google form in 1 week time, and we'll be giving answers at the end of the lecture for you. Because further ado, let me introduce, it's my great pleasure to introduce our today's speaker, who's joining all the way from USA. Uh, our lecturer is Dr. Samandika Saparamadu, MBBS MPH. He's a primary care clinician and public health researcher specializing in public health nutrition, NCD prevention, healthcare delivery, and health policy. He's a founding president of the Sri Lankan Society of Lifestyle Medicine and the founder of Preventive Research Center in Saparamadu University. He is currently works at John Hopkins Bloomberg's School of Public Health in Maryland, United States, as an appointed assistant scientist and serve as affiliated faculty at the College of Public Health at George Mason University in United States. He serves on executive board of the World Lifestyle Medicine Organization in Geneva, and he is the president of Asian Lifestyle Medicine Council. In addition to his research and publication, he has authored two textbooks chapters on NCD and public health nutrition, which is currently on press. He is also served as editor for multiple journals and is currently a special issues editor for Frontier in Epidemiology. He was recognized among 20 under 40 health promotion finalists by the American Journal of Health Promotion. He continues to bridge academic research and local implementation to strengthen public health, nutrition, primary care, and preventive health system. Samandika, this session's over to you. You can start now. Thank you.
Thank you very much, Dr. Himal and Dr. Madhuvanti. Really appreciate the opportunity. Thanks for having me. Since we have quite a bit of things to discuss, I'll straight away get to it. If you have any difficulties in hearing or any visual problems or can't see the slides or videos, sounds, please let us know. Try to work around any issues. So, yeah, thank you. It's a great turnout. The topic today is integrating lifestyle medicine into internal medicine and primary care for non-communicable disease prevention and management. And thank you very much, Dr. Himal, for the lovely introduction. I have nothing to disclose for this webinar. So I try to summarize like what we are trying to achieve today in the simplest way possible. So we'll try to find a practical way of delivering care for non-communicable disease prevention, management, and remission in busy clinic settings that is affordable and sustainable. I think the keywords are affordable and sustainable. So this is the outline for today's talk. There's a lot of things, so I try to kind of summarize it in a way that's easy to follow for today's talk. So let's say we'll start with the problem, how and why of the problem. And then let's go into the evidence-based solutions and why are we proposing certain things, who, what, where, when, why, and how around the evidence-based solutions in a more from a local perspective, what we can do in the practice, what we can start right now. And then some of the implementation strategies that's mostly based on some of the experiences as well as common knowledge, and then some benefits and limitations of what we're discussing today. And finally, system integration, which is probably the least important part. So with that, let me get to the challenges faced by the traditional systems. Particularly, these statistics are all from Sri Lanka. And I'm very sure that everyone is very familiar with these issues. And of course, you have the lived realities. You know exactly how this plays out in the practice. But let's just go through some of them. And I have not provided references to all of them because these are very easy to find statistics and researchers. There's plenty of them out there, except for the high healthcare utilization, which you can find from the WHO, the Sri Lanka health system analysis. So first off, one of the problems we have in practice when we are trying to address the non-communicable diseases and the cardiometabolic risk factors that lead to these disease conditions is the unavailability of effective interventions, or rather ineffective interventions. The second is the doctor-patient ratio. So these two things often work hand in hand and make things worse for the number two issue, which is the limited consultation time. Let me take a step back and go back to the effective intervention part and the doctor-patient ratio issue in Sri Lanka, because that effective intervention part is going to be part of our main focus. That's where we are going to talk about the affordability, sustainability, etc. For the rest of the discussion. When you're looking at the doctor-patient ratio, I'm sure you are aware of this. We have about 1 doctor per 1,000 population very wide range of estimates being published, but roughly around that in the recent past from a WHO statistic. But if you can guess, like, what's the rural area when you go out of the city limits, what's the doctor-patient ratio? Please put in the chat box. So it's much lower, uh, uh, as you can already guess. The limited consultation time, again, a huge variety of numbers, but overall, it's always hovering around 1 minute to 5 minutes. And from some statistics, like even the average is around 1 to 2 minutes. So that's not a really healthy situation to be in, especially when we're talking about it's something like, for instance, if it is diabetes or hypertension that we can't really cure by giving a tablet. Whereas if it's a urine tract infection or something else, that we can actually do that without much of a trouble. So the third issue we are talking about is the high healthcare utilization. This 5 visits per capita. So these are the outpatient visits from Sri Lankans per annum in a year. One person, about 5 visits per capita per year. So that's a very significant number of healthcare visits. Why is it when you compare this number to all the other South Asian countries, it's actually the highest in South Asia. And even when you compare it to OECD countries, it's very high and higher than some of the OECD countries, not all of them. Even the hospitalization, the same problem, highest in South Asia. This is roughly about 1 in 4 people may have had hospitalization per year. So that's a very significant number to keep in mind. And the last thing is about healthcare financing. So we don't have to go to the details of like what proportion of the GDP has been allocated for healthcare and those high-level discussions. But in a very simplistic sense, like if you look at effective interventions, doctor-patient ratio. So now we know we have a very low number of doctors per 1,000 population, and we have limited consultation times. All these things drive up the cost, and what ultimately results in is patients end up paying a higher amount than they used to pay. So that makes it a very bad spiraling or rather negative feedback loop where everything starts going down the drain. So we have to start working on some things. But first of all, let's go back to this healthcare utilization statistic. And this is from the WHO report. You can see the comparison. Even though the OECD countries in general, on average, is higher, when you compare to some of the OECD countries, Sri Lanka is actually still higher. But again, I need to qualify this statement. The reason being, these statistics are actually coming from consumer surveys. These are not like objective statistics, but these are consistent findings. So, and also based on your experience, probably you know better than I do how the healthcare utilization works in Sri Lanka. And when you compare it to the annual consultations, you can see a Sri Lankan doctor annually consults about 6,000 consultations, which is, you can compare the numbers here. So all in all, we can't solve all these problems tonight, for certain, right? And we can't even probably solve any of these problems, but we can try to see what we can do right now in areas where we can work immediately, like for instance, your practice, your clinical practice. So let's focus on these two things: how to find effective interventions and how to find the solution for limited time in consultations. In case you're wondering, another thing I want to highlight here is that we often talk about behavior change, health behavior change, and other things that are related to health, but are not directly biomedical within the biomedical paradigm. And these are generally called the social determinants of health. So by definition, social determinants mean non-health factors that affect your health or health outcomes. The things that happen in the places where you're born, where you live, where you work, and where you stay most of the time, not the places where you go when you're sick. So those factors have a tremendous influence on your health outcomes, which are ultimately, in a very simplistic sense, it's a length of life and quality of life, right? It's in this day and age, we often tend to call it the health span. But whatever it is, it's about we are trying to improve the morbidity and mortality for people. So when you're trying to do that, you can see the contribution from different factors. So health behaviors contributes about 30%. Again, these statistics are coming from very a little bit high level, for example, Vaughan blinder decomposition analysis, etc. So it's not 100% accurate. I can't say that, oh, this is exactly what works for you. But overall, we know that these are the findings consistently in the history, and we know fairly certain. For example, if a country has shown improvement in their health statistics from 1960s to 2025, we can't really give the credit directly to the health minister. So rather, maybe it's something to do with the economics, or maybe the social mobility or something else. So often that's where the change begins, and that's where the most of the influence is. Not to say that clinical care and curative sector is not important. It's very, very important, and it should be at the highest quality of care. But there are other things that you can manipulate and that you can influence during your practice itself to have better outcomes, if ultimately what we're trying to do is to achieve these two things. So again, back to the topic, health behaviors about 30%, clinical care about 20%, social and economic factors about 40%. So that's the usual confounder we always see as a pattern everywhere we see when it comes to education, health, etc. So we are going to talk about these two things as well. So what we're going to do is look at how health behaviors and social and economic factors can be influenced during your practice, and how to make it sustainable and effective and affordable. So with that, let's take a look at what is lifestyle medicine and why are we talking about this. So I know probably many of you already know the kind of definition and the 6 pillars and all these frameworks. For the sake of saving time for the later discussion, let me very briefly say, so lifestyle medicine is a discipline that brings together a couple of subspecialties for the purpose of delivering non-communicable disease care in an effective way. So these specialties, or rather focus areas, formed into a framework called 6 pillars of lifestyle medicine, and that is literally the 6 pillars you can see in front of you, starting with nutrition and diet, physical activity and exercise, managing your stress and mental health, social connectedness, positive social relationships and positive psychology, restful sleep, meaning the quality and quantity of your sleep, and avoiding risky substance use, mainly focusing on alcohol and nicotine, and more with other substance uses as well. So when you look at this framing, you might be wondering, like, we already have all these things, and why do we need a different framing of this, the same thing that we are going to, we already know? So one of the problems is, it's actually twofold. One is, even though we have it, like for instance, if you have a patient who has multiple disease conditions, multimorbid patient, you will have to often depend on multiple specialists or providers to manage that patient. But often over time, we have realized that this is not a very effective way of delivering care. It's very expensive, and it would end up wasting a lot of time for everyone, but not in a very good way, because when you look at the results, ultimately the health outcomes not very good either. So this is a very good way of framing or planning education, training, research, as well as the program delivery in clinical settings as well as in outreach programs. The second is, it's a very good way of bringing the public health discussions, or rather the preventive medicine discussions, into the clinical medicine sphere. So those are the two most important things, but that's not all. So these 6 pillars go into different aspects of lifestyle medicine discipline. For instance, this is a very simple illustration of what are the things that actually form the discipline of lifestyle medicine. Number 1 is the health behavior change using multimodal interventions. We'll talk about it a little bit more in detail later. Then social, how to influence or how to affect the social determinants of health within your practice, how to deliver the care, because there are multiple ways of delivering care for non-communicable diseases, and then how to personalize care, because some of these delivery mechanisms involve people getting together and doing things, even in those kind of situations, like communal activities. We have to find a way how to personalize care for each person's needs. And then finally, social prescribing. So ultimately, when you look at these 6 pillars, this is what goes into training, education, research, and program planning. But it goes, the main components of lifestyle medicine actually is consist of very different other important areas that are critical in delivering care and actually addressing a patient's problems. So this whole story comes about, has come a long way, and let's go through the history very briefly. So this is one of the papers from 1993. They were examining the 1990 death or mortality data from the US. They found out that most of the deaths, about 50% of the deaths, are attributable to tobacco, substance use, diet, and physical inactivity, alcohol use. And then at the conclusions, they they mentioned a couple of things. I thought this is interesting. They were pointing towards how certain public health interventions are important and change can occur. And that was about 30 years ago. And we still see some of these discussions now only starting in some parts of the world. And even in the place that it was first explained in more concrete details, more concrete data, they haven't made much progress either. So another interesting study is the Earl Ford study, where they found out after adjusting for the confounders, the hazard ratio for developing a chronic disease decreases progressively as the number of healthy lifestyle factors increased. For example, like developing a few healthy behaviors can have a major impact on your risk morbidity. So basically, every additional health behavior you have reduces your risk, the dose-response relationship. So there's a lot of studies, but let me give you a very brief overview of how this timeline worked out. Let's make it very, very brief. So first of all, we were talking about social determinants of health, how non-health factors can affect your health. So these discussions have been there since early since 1840s. So you have heard about Virchow. This is the same Virchow that we learn in medical school. So his paper, as well as Edwin Chadwick paper about how social class and occupational occupations are related to the deaths across the UK. And it's surprising that when you look at the papers, when you look at the reports, you realize like how much they knew back then. And what's surprising is because that knowledge has been there for so many years, but still we face problems with these very obvious issues. And early empirical evidence. So this is also an important study that was again published in conducted in the UK. They were looking at how different lifestyles, when people are given opportunities to live in a very different communal setting where they have access to sporting events, exercises, good food, and how these people continue to flourish and have better health and better education and all sort of other better outcomes. There are interesting videos about that as well if you're interested. And the landmark, these are some of the early smoking studies. So by 1950s, we started realizing, okay, this famous Dolan Hill study and linking clearly the smoking to lung cancer, for example. And it was only in 1953 we started realizing actually physical activity has a very important role in causing coronary heart disease. That was again using very simple data, using the bus drivers versus the conductors and their physical activity and connecting them to the incidence rates of heart disease. That was again conducted in the UK. So similarly, you can see the timeline, how it evolves. And one thing I wanted to emphasize here is that, so this is again, one of the famous studies, Framingham Heart Trial, the place where we started learning about the term risk factors. And by 1970s, we knew all of that fairly certainly. And people were thinking how to intervene. Now, what can we do about it? And North Karelia project from Finland was one of those where people started actually using. The Puska is one of the persons who actually led the project. I think he later became the Minister of Health in Finland as well. He still writes about it from time to time. So they had the highest rates of heart disease among men and major risk factor in the world. In the world, they had the highest rates of heart disease from the reported data. And the major risk factors were smoking, diet, particularly very oily and very cheese-heavy diet, and physical inactivity. And they started approaching it in two different ways. One from community side, community-based interventions to get people more active, eat healthy, etc. And clinical side, streamlining processes, getting people screened, treated, and follow-up care, making sure that they are enabled in a way that they can actually sustain the health behavior change. So, but even back then, we didn't have a clear grasp on how to do this in a clinical setting. So that started shaping like much later. We'll skip some of these discussions since there's quite a lot of things to focus on later. So for instance, the lifestyle modification trials, the famous trial from Dean Ornish in 1990, the first randomized control trial that demonstrated the angiographic regression of coronary atherosclerosis in a group of people who were randomized, who were waiting for CABG and who were randomized into intensive lifestyle interventions versus the surgical group, and the outcomes were very significant. Even though the sample size was small, the outcomes were very significant and was in fact published in Lancet as well. So since then, we have known quite a lot of things, but still, there are a lot of gaps in what we are practicing today. So let's get to that finally. So when it comes to evidence-based solutions, the rest of the questions are about who, when, and where. Who's going to do it? Like, for instance, as a participant of today's discussion, when we ask about who, this mainly comes down to the physician and potential facilitators. Who are these facilitators? This could be your clinic staff, your assistant, or it could be a nursing staff or a pharmacist or anyone who can be trained with some health background who can be trained to be a facilitator. And physicians, of course, led by a physician is an important part because we also need personalized care in everything we do. And the second part, when it comes to when, we can do these things in consultations, not just during consultations, even before you start the consultation and the follow-up. Very important part, actually, the follow-up care. And finally, what are the settings? Clinical settings, that's our focus. And the second is actually outreach programs, which is, I found a lot of local doctors found it interesting, especially the family physicians, general practitioners. They love going beyond their clinical space and going to the community and conducting programs. Perhaps it's a win-win situation that helps them to let people know that there's a clinic. At the same time, you do some good work in the community. So I think it's a really interesting situation, but probably it's not very relevant to internal medicine given your work focus in the hospitals as well as in the private practice. It's probably we'll focus on the clinical settings more for today. So who? The physicians, facilitators during consultations and after consultations in clinical settings. So how can we go about it? So I have summarized it into 4 main themes. First of all, the sensitive screening tools. So remember, like, we are trying to understand, like, whatever the simplest things we can do starting from now, whatever the simplest things you can do starting from now in your clinical practice or in your hospital. So some of the simplest things you can do is actually employing a sensitive screening tool to understand what are the risk factors of patients, as well as like more objectively, and to streamline things in your clinical setting. Because that not only help to understand and intervene, it also helps you to improve quality of your care. And over time, these things have really good returns. So I have listed some of the actual validated questionnaires, except for the International Physical Activity Questionnaire, which, as far as I know, doesn't have a locally validated questionnaire. Everything else is actually available in Sinhala language. I'm sorry, I could not find Tamil language validated questionnaires for most of them. But yeah, for Sinhala language, we have most of these questionnaires available and ready to use. So there's no reason to say it's not available, because that's also something I've heard very often. Oh, we don't have tools, we don't have screening questionnaires, etc. But the reality is there's a lot of them out there, just that sometimes it's difficult to find them. One of the reasons I think maybe because some of the local journals are not really indexed in some of the databases, but it's not really hard to find. So I have listed all the references as well. So for instance, this physical activity questionnaire, even though it's not validated in Sri Lanka, it has very high external validity, very good external validity. So it can be with a simple translation and simple testing, you can actually adopt it in a clinical practice. It's very simple, very easy to use. For most people, it will take about 45 seconds to 60 seconds to complete it. And then so basically you can get a really good idea about what is the level of activity, and it can be used for intervention, monitoring, as well as for research purposes if you're interested. And then Global Physical Activity Questionnaire version 2, this has been validated again to measure physical activity the same way, and but it's a little bit longer questionnaire. The patient health questionnaire, this is for depression severity, and then perceived stress scale, again validated in Sri Lanka. Very brief questionnaire, easy to use, self-administered, and can be used especially before your consultation starts. If you have another way of either for existing patients or new patients, a couple of these tools can help understand what is the burden of the problem and what is the gravity of the problem. And when it comes to sleep, this is not the ideal tool, I agree. Pittsburgh Sleep Quality Index, very good questionnaire and very high sensitivity and specificity, but it's too long. But we can use simpler versions, and sometimes even can pick some of these questions from these questionnaires just for the purpose of monitoring, identifying risk factors. And then the weight efficacy, this weight efficacy lifestyle questionnaire is just 8 questions and very, I think it was only validated in female overweight community, a group of people. So not ideal for everyone, but very easy to use questionnaire, especially for long-term monitoring when you are thinking about health behavior change for persons, for people who are overweight or obese. And finally, the depression scale, which is also validated. So basically, I'm not trying to give an exhaustive list of sensitive tools. The idea is that you can start from where you are with a simple screening tool, and that could be the first step in this journey of thinking about what are the effective and efficient lifestyle interventions you can actually administer. Because first of all, you need to understand the problem. So this is a simple way of doing that. And let's talk a little bit about effective and efficient lifestyle interventions. There's so many of them, but I did not mention everything. The reason being there were no many locally derived evidence. So I have just focused on 2 really good studies. The first one was kind of too good to be true, but anyway, I mentioned anyway because the effectiveness was it's over the roof. It was like 61% cessation rate from a brief tobacco cessation counseling program that took about 3 to 5 minutes by the provider for counseling, just highlighting oral health effects of tobacco and providing quit advice. And the cessation rates were significantly high. They did not have long-term data, but the idea is by the few minutes you can make a really big difference. And if you remember in medical school, I think it was always said, like, just tell a person who smokes not to smoke. Take 10 seconds and say not to smoke. The problem with that strategy is there's a lot of evidence that it leads to about 10 to 20% of quit rate, but long-term follow-up data shows that cold turkey, which means like cold turkey quitting, which means you quit immediately, that doesn't really have great sustainability data because people often get back to their bad habits. So it's always, so far, the evidence has converged into 2 important things. One is having a plan and using the pharmacological support to help them quit. Like, for example, simple things like nicotine patches, which is available in Sri Lanka. I'm not sure whether varenicline and other things are available, but you can start with simple things. Again, I understand the problem with the cost, but let's talk about it later. And just to mention, this study did not use any medications. So more reasons why things are actually possible in the local setting, because especially when it's coming from a doctor in the local culture, I think it carries a different weight. And that doesn't happen in every country. So in certain cultures, certain countries, that happens. So it's really good to leverage those type of cultural nuances so that we can actually make really good differences in people's health outcomes. The second is this is also a really good study which showed concretely, with concrete evidence. You can look at the odds ratio. It's about 7.8, about 680 times. It's 80% difference between the intervention group and the compared to the control group. So simply they used a behavior change counseling session, telling people how to cut down salt and sugar and how to improve their fruits and vegetables intake via a short education and motivation session during consultation, very brief. And results were significantly extremely significant, and to a level actually I could not even believe initially when I was reading the paper, but methods are very solid. So the downside of that is we don't really have long-term data. One is it's quite expensive to conduct these type of studies for a very long period of time, but always there's opportunity to go back to the populations and to find out what has happened after about 12 months, because that's another thing we are going to talk about a little later. There's really good data about how these interventions, simple interventions that is very efficient and very effective, can be used in the clinical setting when you see the patient right there. But sometimes the sustainability is not that great. So that's where we need to focus a little bit more about follow-up as well. So the next is, let's talk about another way of delivering care, which is called group medical consultations or shared medical appointments, or called group consultations, or whatever you want to call it. So I'm not going to talk a little bit too much about it, but let's watch a video, a very short clip, just to see how it is done in a clinical setting. You might be like, okay, no, this is not for me. For some people, well, yes, this is not. Again, this is not for everyone. Some people, I think it depends on the personality as well. Some people like to have a group of people to come together and for a shared purpose and to navigate that conversation. But rightly said, it's not for everyone. So if it is for you, maybe there's plenty of evidence and plenty of materials for you to read and understand. From Sri Lankan Society of Lifestyle Medicine, we did a webinar on shared medical appointment, which is also available to, if you want to dig into the details and know exactly how to do it in clinical practice. You can find it on the YouTube channel. Because we are not going to talk too much about it today, but very briefly, this method can be used in multiple conditions, from simple things like, hypertension, cohort of patients with hypertension, or cohort of patients with diabetes or multimorbidity, etc. Evidence, there's a lot of generally moderate evidence and on improved self-efficacy. Again, we have a little bit of problem with long-term evidence. So that's where the continuity of care and follow-up is very important. And finally, extremely effective in reducing, your obvious clinical outcomes like HbA1c, controlling blood pressure. Like, for example, just take a look at this meta-analysis that was published in the Canadian journal. You can see there's very clear improvements in diabetes outcomes. So this is just the blood sugar control. And one of the problems this is the findings are not consistent. There's a really good reason behind that. That is, when we're looking at controlled trials and a single health behavior change interventions, they are very well controlled. Whereas when it comes to group practices, it depends on a couple of different factors. So it depends on how well the facilitator might be prepared for doing that, and how well they are receptive to patients, and how well the group of people gel together and create a kind of very, the group dynamics. It depends on the group dynamics and a couple of other things, including the facilitator's personality and etc. So that's one of the reasons why, because we can't 100% control these type of situations. And in fact, by design, it's not supposed to be controlled so much. It's supposed to be a fairly free space for people to share their experiences, learn from other people's success stories, and reinforce your self-efficacy and accountability through the peer learning process. So there's a lot of really good evidence and theoretical basis for that. But in practice, as I said earlier, it may not be for you, but if it's for you, I think you should definitely take a look and see how you can incorporate these things in a clinical practice. Obviously, you need a little bit of more space. Like if it's a really tiny space in a channeling center, that might not be the right place. But if you have like 100 square feet meter, 100 square feet room, I think that's more than enough to get started with a small group, because usually these groups do not have more than 8 to 10 people. Sometimes you can have about 15 people, but it'll be way too many people to handle in a 45 minutes to 60 minutes session. So with that, okay, I think we'll watch the video a little later, and let's go to these multimodal interventions. So now we were talking about screening tools, how to get started immediately. If you want to do it tomorrow, you can do it. And then after identifying some of the problems, what you can do effectively and efficiently in a clinical setting, and then a different way of delivering that care to a group of people instead of doing it one-on-one, which also has its own benefits and limitations. And finally, the multimodal lifestyle intervention. That's one of the most important things in this package. The reason being, there's a lot of evidence that when the lifestyle factors, like the very first paper we were talking about, Earl's paper, when you have each additional good health behavior you are reducing your risk of acquiring a disease or having a major adverse cardiovascular event. So, there's a synergistic effect as well. So there's a lot of data show that it's not additive. It's not like having a healthy diet plus having a healthy diet, let's say it includes X amount of years to your life, and getting active, having an active lifestyle is Y amount. So both behaviors is not X and Y, it's X plus Y plus a delta. And so there's a little bit of a synergistic effect. So the total sum of things is not equal to the absolute total. It's a little bit more than that. So that's why it is very important. But there are two different terms that have been used in the literature as well as in the practice. So one is multimodal lifestyle intervention. The other one is multi-component lifestyle interventions. There's a lot of interchangeable use you can see in the writings, but this is how I differentiate these two. Multimodal means you are addressing multiple health behaviors at the same time. For instance, let's go back to the 6 pillars of lifestyle medicine. Let's say from diet and nutrition, physical activity and exercise, smoking and alcohol cessation, to and mental health and stress. You address those 4, and you leave your social connectedness and sleep just for the time being, or you add all 6. So that's multimodal lifestyle intervention. Multi-component is somewhat different. We are talking about mainly the strategies and delivery mechanisms. For example, after your appointment, maybe you have a tech-based like application that people get some nudges, some messages, like prompting them to sustain their healthy behavior that they have chosen for that week or that month, etc. And or else maybe it is a follow-up care visit by a different healthcare provider, or else it could be what you have given as a checklist or some sort of a diary or something else that they want to that you want them to continue as part of your care plan. So multi-component means you're combining a couple of different things. It could be technical or IT-based solutions and actual human interventions, multiple components for one or more health behaviors. So there's ton of evidence for that. So I'm not going to talk a lot more to convince you. So instead of thinking just one intervention, it's always good to start with one simple thing that people can do. That's true. Like if you have multiple risk factors, a person who's obese, who has hypertension, diabetes, etc., like the whole package, plus they have multiple behavioral problems. They smoke, drink alcohol, and don't was completely working on sitting in front of a laptop and no exercise at all, and eat a lot of junk food. So yes, in that type of situation, it's good to start with something simple like low-hanging fruits and work your way towards the other pillars. But it's always important to bear that in mind. It's not just one thing. You have to see how else you can optimize it, because these marginal changes have really good dividends when you continue to do it for a long period of time. So you can see this is a meta-analysis of about 12,000 plus people, almost about 13,000 people. And they found like it's more basically comparing. Let's go to the summary slide. You can see if you just focus on the red area on the right side, this is a more intervention, more effective ways of delivering that care. You can see on the right lower corner, the diet plus the exercise that has the highest level of evidence, and it's way more effective than each intervention alone. And similarly, this is the study conducted around different components, or rather multi-component. So what did they do? They used educational, motivational, and behavioral components together for health behavior change. So again, more you have, more pathways you have to influence their health behaviors, it's more effective. Simple as that. This is the main results page from this paper. You can take a look, as well as I think I have put down the references. So with that, let me just quickly go through some of the other things that you can incorporate in this story. Like, these are not generally like nothing specific to lifestyle medicine or internal medicine. This is generally in healthcare. So always think about having a patient registry or quality improvement processes that you can incorporate into your clinical care, because these things also have a really good use. Like, well, we can probably address some of these things during the Q&A session. With that, let me go to where you can start, what you can do. So this is not entirely evidence-based. This part is like based on some of my personal experiences, as well as what we already know. So you can start, as I always say, like, start where you are. You don't have to wait for something to happen, because what are the chances everything comes together for you to start something? Well, very unlikely. So you have to start from where you are and start with something simple that you can use. For example, starting with a screening tool or simple registry, so that you can start understanding patients better, as well as understanding how things change over time, understanding the trends, and monitor them more effectively. And use in PGIM and foreign training, as I understand, there's a lot of emphasis now on quality improvement, a lot of audits, clinical audits being conducted by Sri Lankan doctors. So leverage that in your clinical practice as well, because these things, again, as I said earlier, it might sound simple. Even if it's not your own space, you can still do it. As long as you have a functioning clinic system, you can start thinking about how to improve the quality in the processes. If your patients are not turning up, at least, okay, let me take a step back. If you have, let's say, 300 patients in your registry, you are seeing about roughly 300 patients in total for a year, and now you're seeing the same set of patients coming back again in the second year or the second half of that year. And if you see a lot of people missing their appointments, they're not coming back 3 months or 4 months after your follow-up. So that's a really good place to start thinking about, how can I do differently? How can I improve these things? But unfortunately, you would not know unless you track it, unless you measure it, unless you start documenting it. So that's something simple you can start in any kind of practice. All you need is sometimes just a simple Excel sheet. Or these days, there's a lot of other free available IT solutions as well. But essentially, all you need is a simple Excel sheet. And collaborate and talk to researchers, because there are a lot of people who are interested in measuring the outcomes and what you do and what you achieve. So that will make it easy for you to implement certain things and to understand without spending too much time and worrying about how to measure. And train your staff, especially clinic assistants. I think there was a very interesting discussion, I think, between executive from Apple. It was asked, why do you want to train people every time when you know that they keep leaving the company? They said, why do I want to keep people if they're not trained in that case? So you end up having people who are not trained and who are not really good at what they're doing. So taking about an hour a week is definitely not a wasted experiment. I did myself when I was practicing in Singapore, and that paid off really well. And a couple of more things. One is make health behavior change a priority. I know a lot of you probably in practice always get your HbA1c periodically, get your blood pressure measured and documented. Besides that, try to track the health behavior change, all the components of different components of health behavior change, that because ultimately we know how those things are connected to each other. So instead of just keeping eye on one thing, maybe just expand a little bit more so that you can see how these ultimate results that are important to you are shaped by things that are a little bit more important to your patients or more beneficial for the patients. And join collaborator networks. There are opportunities to learn by doing it. We also have a collaborative network at the Preventive Research Center. I will share the details later. And leverage technology. Leverage technology. There's so many things you can do with technology. I know sometimes it feels kind of overwhelmed. There's too many things, too many apps doing the same thing, but identifying the right thing in the right time will also, because there are a lot of technology that has been developed in Sri Lanka, but unfortunately, it's not really discussed much. So for instance, there's a new large language model based follow-up care app developed in Sri Lanka. I don't think it's fully available in the market yet, but it's very difficult to find these type of solutions out in the market. So you need to just dig it up and find out what's there for you. So for example, Diet ID. I don't think this is validated in Sri Lanka, but what they do is they give patients a set of pictures. So they keep choosing like basically A/B testing. This is more likely your diet. This is more likely your diet. So they keep choosing pictures one after the other, and after a sequential set of photo selection, it gives you a really good estimate of your actual diet. What are the components of your diet and nutrition intake on average? So these save a lot of time and help you understand your patients better and track them better. So this is the video. I don't know whether I have time, but what I can do is I'll put the link in the chat later so you can watch it at your own free time. This is just a simple illustration of how group interventions or group consultations are conducted. As I said earlier, if you want to learn more, there's a lot of materials out there on the internet as well. Let's briefly talk about the benefits and limits. So, ton of benefits for doctors. The good news, one starting with satisfaction and the long-term investment you have, and also the consistent patient engagement and income stability. This is also an important thing. If you go back to the one of the initial figures we discussed briefly, you see how many consultations a doctor has a year, right? But on average, if you look at a little bit more organized systems, you can see about a doctor with a full practice has about 800 patients in their registry. So there's a continuous the continuous follow-up as well as it's a good patient rapport. They know each other, they know their problems, and you can address things better. So having that consistent patient engagement and income stability is also a really good thing that can come with this by engaging patients in using these techniques and interventions. And finally, for patients, the NCD-related outcomes, level of satisfaction, and cardiometabolic risk factors. There's a ton of evidence for all these different things, especially for patient satisfaction, cardiometabolic risk factor improvement, as well as the physician satisfaction. And there are a couple of limitations as well. So first off, the readiness on both sides, the physicians and patients. As I said, that's why I've been saying like multiple times, you don't have to wait for everything to come together. You can start from wherever you are. And the limited public sector investment, that we will not talk about today for sure. And finally, implementation costs and infrastructure, which are frustrating things, but because in a hospital setting, you would see there are certain things you want to do, but you can't do because of the facilities you have around you. And if it's a clinical setting, you would see it's a tiny channeling center. There's no space to move around, and a lot of these type of frustrations. But ultimately, the bottom line is there are simple things you can start with starting today. So the last thing, we'll just glance over it within a minute or so. So this is how to use these things in a clinical practice. You don't have to focus on, sorry about this very busy slide. These just think about these categories, like how these things can be combined into a healthcare system, or how these things can be incorporated into a healthcare system for better delivery of care for NCDs and risk factors. So you can see how group consultation, social prescribing, and technology-assisted follow-up, and the lifestyle medicine for the purpose of, again, as I said, mainly for the purpose of teaching, training, research, and program planning purposes, and the multimodal lifestyle interventions, which are embedded in these programs, and finally, financing mechanisms and health promotion process. Health promotion process is another long discussion. Some of these things have their own probably worth their own webinars. So let's not get into the details. And this is how it look like in a healthcare system if you just focus in on the green part of this figure. So these are a couple of things that easily can be combined for a very effective healthcare model. So with that, let me conclude by saying, let's take baby steps. Just think about whatever simplest thing you can do. And given the benefits these interventions carry and have for the patients and doctors, I think it's really worth a shot. So here's my contact details. And maybe I'll just post some of these things in the chat. Over to you, Hima. Thank you.
Thank you, Samandika, for this very comprehensive talk regarding disease prevention and the management. So for the audience, we'll be answering your questions soon after, and we will be displaying the QR code and posting the Google form link in the chat box in a couple of minutes. So meantime, since I got a couple of questions to me in my hand, shall we start the Q&A, Samandika? Is it a good time to start? All right.
Yes.
Now, the first question is, so we discuss about how we assess the physical activity, and there are lots to things to do at clinic settings. We don't have much time. So what do you recommend to have ask patient or patients how to assess with the shorter period a patient's physical activity?
Okay.
What kind of question are you suggesting to use?
Okay.
There's a questionnaire called PQR 2021, which is very simple. So do you have any other suggestions?
Now, I think I would go back to the same thing, because even though it's a 7-item questionnaire, it's
Yeah.
2 questions each are actually interlinked. So basically asking simple things like, are you engaged in moderate activity, moderate intensity exercises with some examples, and then how many hours a week? And then whether you are involved in any mild activity exercises like walking, brisk walking, etc., and how many hours a week? And finally, any high intensity exercises and how many hours a week? And then we can estimate your level of physical activity as well as the the number of METs you meet a week, and then you can think about the interventions that that person might need depending on the other risk factors altogether. So again, I'm going to go back to the same questionnaire, the 7-item questionnaire, because even though it's 7 items, as I said, it doesn't take more than 45 minutes to 60 minutes to complete. You just need a Sinhala or Tamil translation, and that's all you need. Oh, and one more
Let
thing.
me remind. Yeah.
Sorry, one more thing.
Yeah,
You'll
please.
also need to customize the examples, because a lot of examples often include things like swimming and like various activities that Sri Lankans don't usually get engaged. So yeah, you have to look up what are the right activities for those gradients of METs that you get from different physical activity levels.
Shall we remind the questionnaire again to the audience, Samandika? I think this is new to them.
Yeah,
It's
I'll
better to
put in.
remind them.
Yeah.
Yes, please.
Put on.
My next question, second question is, in a clinical encounter, we usually don't ask about the sleep. There are questions to assess OSA, stop and ban, and the lot question is also a patient who has a OSA or any other sleep disorders. But we generally don't ask the questions how many hours you sleep or how good your sleep is. Do you have any kind of a shorter way to deliver or shorter way to assess a patient in a clinic setting? Or any
Yeah.
suggestions, someone?
Yeah, the simplest way is just focus on the quality of sleep and the quantity of sleep because there's a lot of ton of evidence. And that's also interesting. The reason being this evidence actually started forming only in 1970s, 60s, early 1970s. The reason being not that people had a kind of idea, just that most of the trials back then, most of the cohort studies did not capture that idea, that variable as a sleep, as one of the factors. Even the Framingham Heart trial did not include sleep for the first about 2 decades. So very important question. And yes, you can ask simply by capturing the quality of sleep and the quantity of sleep, and then start from there. And if there are any warning signs, if there's any significant differences in the sense by the initial screening, then you can go to the full questionnaire, the Pittsburgh questionnaire.
Okay. Uh,
And one more thing to
listen,
add, I mean, generally speaking, but from all the studies, what we know for a fairly certain that anything below 4 hours of sleep is increasing your cardiometabolic risk, and anything more than 9 to 10 hours of sleep also increases because often it's related to, because it's a confound often, because it may be related to OSA or some other disease conditions and also dementia, etc. So those two things are important to remember.
we have included this question to our registration form as well. Uh, uh, is it, do we have a kind of a solid evidence to say disease prevention, especially disease management, chronic disease management, lifestyle medicine intervention effective as medication?
Right. Is it like asking about whether you can replace medications with that?
Uh,
That's
no,
the implication.
the question is asked, audience is asking whether this lifestyle intervention is it effective as medications?
Yeah. So yes and no. So certain disease conditions, for example, if you look at grade 1 hypertension, there's plenty of evidence that you can manage grade 1 hypertension without medications, just through multimodal lifestyle interventions alone, like simply by starting on a DASH diet, physical activity program, sleep, and stress management. Those 4 things would most likely solve a lot of people who do not have a secondary cause, right? So that is for a fact, but it's not true all the time. Of course, you have to incorporate pharmaceutical management to supplement, because this is not like alternative medicine platform. This is like complementary, not even complementary. This is part of allopathic medicine. It's just that we are trying to see how effectively we can actually use the things that we learn and we talk about in practice. So the answer is yes and no. Certain conditions, yes, you can start without medications, just the lifestyle interventions alone, but it's not always true.
Uh, there's another question by the audience. What about alcohol and smoking in the screening in clinic setting or clinical settings? Do you have any kind of a questionnaire or screening tool very easy to handle at clinic setting?
I mean, those two actually, Sri Lanka has done really well. Like if you see the smoking patterns in Sri Lanka, ever since I think in mid 1990s, during Chandrika administration, they did a island-wide campaign for smoking prevention, and those things have had really good effects. You can see the trends and how the programs impacted. So some of the things that they developed are actually these screening tools. Simple things like even for alcohol, for example, the CAGE questionnaire as a screening tool, right? And that I think everyone is familiar. You can start using it because there are validated tools in Sri Lanka for that. And then for smoking, usually the best thing is just ask directly. Make it as part of your either in-person screening. I think the best use of your time is to do it beforehand. Then the patients are waiting, get them to fill the form, including the smoking habits. Like just need to ask whether you are a current smoker, past smoker, or non-smoker. and then the smoking type of tobacco product they are using, and finally, the frequency of their smoking habits. That's
Our
the
next
question.
question is,
Okay.
yes, our next question is, is there any place for intermittent fasting in insulin resistant management? This due to diabetic management.
Hmm.
Yes.
I think I would not, because that's going to open a different conversation. I'll rather keep it for the next webinar. You can probably get an answer directly from the nutrition talk. They will definitely that'll be part of the scope of the talk. Because because you can't answer directly given the nuances around that idea. So I'd rather not answer it right now. But let's keep it for the next webinar.
Let me ask a different way of this question in regarding diabetes, because a lot of people are asking this question. Is there any robust evidences to reverse remission diabetes with lifestyle intervention alone?
I mean, obviously, answer is yes, because the trials came out more than now by today, it's almost about 2 decades ago, the first direct trial, right? The direct trial had initial populations, and even we did there was an internal analysis that was done in Hopkins using the same data, looking at the influence by highly processed food. So the answer is definitely yes. Diabetes can achieve remission, right? But it doesn't mean it's a cure. So you can't expect it to go away and never come back, because the moment your bad or unhealthy lifestyles kick in, of course, you will start developing your insulin resistance. And as long as it's a type 2 diabetes patient, you will continue to have those risk factors, just the matter of how well you can manage the condition. And answer again, very, very concrete answer. Everything has been directed to your total calorie intake, right? Mainly your total calorie intake, because the moment your diet goes beyond lower than like 1,500 calories, and in some extreme cases, 1,000 calories, which is difficult to manage, which has a lot more adverse effects than a 1,500 calorie diet, it can lead to, with a certain amount of body fat percentage reduction, for example, about when you achieve about 10% reduction in your body weight, so that you start seeing the results aiming or rather indicating a story about remission of diabetes. Yeah, but again, as I said, it needs a lot of consistent effort, and just because it has achieved remission now, it doesn't mean it's not going to come back again. Yeah. If you're interested, I think start reading from the direct trial. So that's the most conclusive evidence we had. I think it was published in NEMJ.
Thank you. A lot of people are discussing about gut microbiome as an important role of a healthy life. So, does any lifestyle intervention or lifestyle measures can improve gut microbiota to prevent chronic diseases?
Okay, let me start by saying I'm not an expert in gut microbiome. It's not one of my interest or expert areas. So I would just say the general knowledge around it, but you'll have to ask this question separately in a different lecture. Probably in this series, we'll have one person who's good at talking about it. So simply put, for example, if you look at the Mediterranean diet, which has linked since Ansel Keys' first experiments in 1960s, 70s, Mediterranean diet has been kind of part of the forefront of lifestyle, right? If you have this Mediterranean lifestyle, if you have this Mediterranean diet, both are two different things, have been assessed very differently, but ultimately Mediterranean diet, Mediterranean lifestyle. If you have those things, you have lower risk of a lot of other things, including cardiovascular risk factors. So that has been linked to better gut microbiome. So basically, ultimately, it all comes down to a well-balanced diet with more fruits and vegetables and reduced refined sugars, oil and salt, plus reduced intake of highly processed food, which is by, sorry, I can't remember the name of the classification now. So ultimately, if general advice, I would say, once again, it's not my expert area. So general advice you can give simply is at least aim for 2 to 3 servings of fruits and 3 to 4 servings of vegetables a day, with a good balance of calories from the macronutrients.
Right. Since we are reaching our time limit, I will ask one more question from the audience. This question regarding the meditation, which is recommended or not. We discuss in lifestyle medicine a lot about positive social connections and stress management. Will meditation will help to achieve these targets?
Interesting question. Actually, we were talking about Dean Ornish study, right? Like from 1993. But you know, the first trial that was ever published, that was published in Lancet by someone, I think, from India called some Patel. Sorry, I can't remember the name of the researcher. It's a Patel, Dr. Patel. And that was around yoga and meditation to reduce stress and improve health outcomes in NCD. So that was 1969 or 70. So yes, the answer is yes. Since very early in this story, we've known that these things improve your health. It's just that mainly, I mean, the biomedical paradigm, if you explain through your cortisol pathways, so that's the best way to explain how the chronic inflammation can manifest certain cardiovascular outcomes. But all in all, yes, answer is yes, you can improve with meditation and other things, but not alone, not alone. It's just like only not just say, oh, just meditation will cure you. That's very unlikely because those are some of the, when you look at the entire evidence landscape, some of the strongest evidence we have is from substance like nicotine use, alcohol, and I mean, reduction of those things, and better diet and nutrition, physical activity, and sleep. So those four are very, very solid. And from mental health, not that strong. The reason being, it's not easy to standardize and measure those outcomes as well. And also it's very, very difficult to deliver the same thing the same way because it depends on the personality, interest of people who actually administer those programs. So yeah, once again, to recap, yes, those things have implications, but think about the multimodal intervention. Just make it as part and parcel of the treatment plan and your package for the patient, depending on their risk factors, of course.
All right. With that note, since their time has come to the end, we need to round up the session. Samandika, thank you very much for this comprehensive talk and your elaborations. Really great. Thank you for joining with us with our webinar series as a first start. And let me thank all our audience. We had about over 300 participants. Thank you everyone to our participating in our first webinar. And we will be seeing you with another session in next probably next May regarding another lifestyle medicine intervention which can be used in our clinical care. Let me thank our sponsors, Get Pharma, and last on the list, let me thank our whole team in Sri Lankan College of Internal Medicine, who has done a lot to arrange these sessions for you. Samandika, thank you for your help and lovely talk.
Thank you very much, everyone. Thank you, Himal.
Thank you very much, Samandika. Thank you. Good night.
Good night.
This message for the audience. I just posted the Google link to our chat box again, and this link will be there, and this QR code will be there for a few hours. You can go through it and finish the questionnaire, and you will be receiving CPD certificate in 1 week time. So if you have any other questions, you can send to our chat box. We'll be with your email. We will be answering you after contacting our lecturer as much as possible. Thank you for joining. Good night.